All right, the last presentation in this session is done by Dr. Reiter, McCarthy, and Raval out of Lurie Children's as well as Emory University. It's the value of children's hospitals for common surgical conditions.
Thank you for the opportunity to present our work. There we go. We have no disclosures, and this was an R01 funded study. Children's hospitals make up less than 5% of the hospitals in the United States. However, they account for 40% of inpatient hospital days for pediatric patients and 50% of costs of pediatric care. In 2009, 40 children's hospitals accounted for more than $10 billion of U.S. healthcare expenditure. The top 10 children's hospitals profited more than $800 million. For this presentation, we're going to focus on the equation seen here on the slide, which is the value equation, or quality over cost. With increased discussion about value-based reimbursement, we need to understand pediatric surgical care and the value proposition. So our objective was to determine the value of children's hospitals for routine surgical procedures by analyzing outcomes and payments data. This is a retrospective cohort study from 2010 to 2015, including children less than or equal to 18 years of age. We used the Healthcare Cost Institute database, which is a de-identified administrative database for over 10 million privately insured beneficiaries in the United States. The private insurance companies included are listed on the slide. This includes about 25% of privately insured children in the United States, and for reference, about 50% of children in the United States are privately insured. We included 13 common surgical procedures across 5 different surgical subspecialties. And we classified our hospitals as Children's Hospital A, freestanding children's hospital, a Children's Hospital B, which is a children's hospital attached to an adult hospital, or a non-children's hospital. We had 368,220 patients who underwent one of the 13 procedures of interest. 32% of the cases were performed at Children's Hospital A, 20% at Children's Hospital B, and 47% at non-children's hospitals. The most common procedure was tonsillectomy and adenoidectomy, and over 50% were performed at non-children's hospitals. The least common was cholecystectomy, and over 60% were performed at non-children's hospitals. This is a graph showing payments for the common surgical procedures at children's hospitals and non-children's hospitals. The dark blue is Children's Hospital A, light blue Children's Hospital B, and gray is non-children's hospitals. This is a representative sample of our 13 cases, but what we saw for all of the cases, except for posterior spinal fusion, is that there was this stepwise decline from Children's Hospital A to non-children's hospitals, meaning Children's Hospital A received greater payments than non-children's hospitals. For posterior spinal fusion, this was the only case that we saw non-children's hospitals receive more money than Children's Hospital A, and it was only $600. The greatest difference we saw was for appendectomy, and it was over $5,000 more in payment to Children's Hospital A than non-children's hospitals. We found no difference in clinical outcomes, readmissions at 30, 60, or 90 days at any of the hospital types. We then performed a regression, and we adjusted for everything that you can see on the right side of the screen. With all of these adjustments, we still found that Children's Hospital A for inpatient common surgical procedures received 39% greater payments than non-children's hospitals, and for outpatient common procedures received 34% greater payments. Some limitations to our study are that it only includes private insurers. We did not evaluate for referral practices or patient family preferences. The data could be considered dated. We do not account for cost shifting, and our complications were from administrative data. In conclusion, for commonly performed surgical procedures in children, clinical outcomes are equivalent at children's hospitals and non-children's hospitals, but these surgical procedures are associated with higher payments and therefore lower overall value care. Thank you.
This paper is open for discussion. So a question that I have is basically what you're saying is that there's going to be this, basically, there's a tension, right, between the private insurers and the children's hospitals. And children's hospitals are going to want to make money, and the private insurers are going to want to pay less, right? So who's going to implement this to bring down the cost of care? Is it going to be the government? Is it going to be just this constant tug of war between the two parties? Like, how does this get, like, operationalized?
I think that's a great question. I think there are areas for improvement at the children's hospitals themselves. They could look at ways to decrease the cost of these procedures or make them more efficient at the children's hospital themselves.
But not surgeon salaries, right?
We did not look at surgeon salaries. This was the whole amount paid to the hospital by the private insurance company. So we did not look at surgeon salaries.
Question, Duncan Phillips from Raleigh, North Carolina. The payments to the hospital are typically determined by the contracted rates with the private payers, because this didn't include any Medicaid patients,
It did
no
not
government
include
patients.
Medicaid patients.
So is this a reflection of the contracting ability of the children's hospitals? Do they just sign better contracts and therefore get paid better than small community hospitals?
That's something that we considered, and thinking about that, we think about the markets. And so we did a lot of different analyses where we looked at markets where there's children's hospital A, B, and non-children's hospitals, A and non-children's hospitals, B and non-children's hospitals, et cetera, and we still found no difference. And so you would think that if it was just based on the contract negotiation, that if you had, a monopoly, you would see just a completely, like, they would pay way more. And here we see that in all the markets this stands.
Last question, please.
Hi, Baron Modi from Boston. Thank you for shining light on this. I think we clearly need to bring costs down. I do have a question about your methods, though, in terms of telling us that the outcomes are equivalent between the different hospital types. Did you show us that the patients are equivalent across the hospital types? I saw that you had chronic conditions included in your multivariable regression. Were other things like age, for example? In our environment, anybody that's less than 14 is going to get shipped to us, while peripheral community hospitals that are non-children's hospitals will do kids over 14 or 15. That's obviously a difference in terms of the care that we're providing.
Yeah, so we looked at a composite of all complications, so a surgical site infection, deep infection. It was just kind of like an entire array of complications that we put into there, and then the readmission rates and hospital rates is what we looked at, and we found no difference for any of those. We couldn't drill down onto exact patient characteristics for each of them, so we really only had gender, and that looked the same across the different sites.
All right, thank you.